Hi everyone. So continuing on through resistance training, we need to talk about what these general principles are. So how do we apply principles to what we're doing in terms of creating a prescription for someone to do resistance training? So obviously the first thing that has to happen, no matter what, if you haven't gained that by now in terms of what I've been talking about from the first lecture on kinesiology, is you require a comprehensive examination and evaluation. It's the only way you're going to individualize a prescription to meet the needs of whatever the patient requires. So ultimately, as I've said a number of times now, what has to happen is through this comprehensive examination, you're getting a sense of a whole bunch of stuff, where the limitations are and what the patient is required to do to get to where they want to go. So before we even start any resistance training, there's a number of things you need to think about doing. First is to perform a thorough examination of the patient, including a health history, selective tests and measurements, determine qualitative and quantitative baselines of strength, muscular endurance, range of motion, and overall level of functional performance against which progress can be measured. All of that is coming in semester 3 when you start doing your assessment evaluations, but believe it or not, you're actually starting an assessment of your patient now through the pain questions and active range of motion, and that will continue to build as you work your way through. Second, interpret the findings to determine if the use of resistance exercise is appropriate or inappropriate at this time. So maybe the pathology that the patient has or their clinical presentation doesn't warrant an a resistance exercise program at this point. May come later, but not now. And you have to look at, maybe they really want one, but because they have a consideration of a cardiovascular disease or something, maybe they can't do it. Third, establish how resistance training will be integrated into the plan of care with other therapeutic exercise modalities, such as stretching, joint mobilizations, balance training, and cardiopulmonary conditioning. So again, when we're looking at a patient's needs, we have to take into account a whole bunch of stuff, right? In terms of what does the evaluation show? What limitations are in their body? What does the job actually require them to do? I did talk a little bit at the end of the kinesiology lecture in regards to a functional abilities evaluation. So you do have to sort of break down exactly what they're doing in their work or their play or their responsibilities at home. And you then have to figure out how it's going to fit. So this is something they're going to do in front of you in a sense of a gym in a clinic you're working at. Is this something you're going to give them that they're going to do outside on their own, or maybe you're going to follow them for the first couple of times? Occasionally therapists do that as well. And then to reevaluate periodically to document progress and to determine if and how the dosage of exercises and types of exercises should be adjusted to continue to challenge the patient. Remember the overload principle. You must challenge and stress the system out in order to force it to adopt. So you are always looking and double checking to see where the patient's at. So as a rule of thumb, a patient comes to you and says, yeah, that 2 pounds you gave me last week, piece of cake, like it doesn't even bother me now. It's time to take it up and start to re-stress the system. So how do we prepare? Well, select and prescribe the forms of resistance exercise that are appropriate and expected to be effective. Of course, that's going to come out of your assessment, your conversations, your interview with your patient, and so forth. Your ADLs, their ADLs, their functional requirements, and so forth in life. If implementing mechanical resistance exercises, determine what equipment is needed and available. So that's the other part of creating an exercise prescription is where financially is your patient? Are they a member of a gym? Can they afford a gym? Maybe they can't. So now you have to start to strategically figure out, okay, maybe cans of food that weigh a certain amount. Maybe it's resistance bands that you can supply to them. Maybe it's going to the gym, to the park, and maybe their park has stairs, which helps them work. So it's about working with what they have and what they're able to do. Review the anticipated goals and expected functional outcomes of the patient. I think I've said that a number of times. Explain the exercise plan and procedures, and of course, get consent for that. Make sure they wear non-restrictive clothing and supportive shoes, so they're in a good place for it. They should be on a comfortable support surface for exercise. So one thing I always tell patients, if I give them a prescription and they're going home, These exercises are not to be done on their bed. They're to be done on the floor or an exercise mat because the bed doesn't offer enough support for them to safely do the exercises. The other key point is demonstration. So, we've all done the telephone game where through interpretation, things get confused and mixed up, and what you said isn't really what's being heard, and so forth. The best way that you can explain what you want the patient to do is to actually demonstrate to them and then have them demonstrate it back and make any adjustments. That should continue. So if you see a patient a week later and they say, oh, that exercise isn't working, ask them to perform the exercise for you. You will be very surprised how incorrect they're likely doing it, and you have to continue to modify and help them along to make sure they're doing it appropriately. The implementation of resistance training. How do we implement it into the program? And this is the guidelines I have here apply to the use of dynamic exercises against manual or mechanical. So these are all about them just doing movements themselves at home on the floor rather than going to the gym and using machines. So the patient needs to warm up. Go back to that bubble gum I talked about where you put it in a bucket of cold water, that bubble gum doesn't stretch, it doesn't move. You want that muscle tissue to be warmed up so that it's juicy and stretchy, and their percentage of running into injuring themselves becomes very low if they warm their tissues up first. Where do they put the replacement, or the placement of this resistance? So typically apply to the distal end of the segment in which the muscle to be strengthened attaches. And if you think about that kinesiology with the levers, in terms of where you place the resistance on the lever, remember, the farther out the arm you go, meaning the resistance arm, the harder it's going to be for the patient to perform the task. So if you are asking them to do, say, for example, a shoulder abduction resistance test, if you're going to have them go out to their sides with completely straight arms, that moment arm to resistance is quite long and they're going to find it difficult. Maybe in the beginning, if they're not that strong, you start with the elbows flexed and move up accordingly, thus shortening the moment arm and making the work a lot easier. Distal placement generates the greatest amount of external torque with the least amount of manual or mechanical resistance. So again, opposite to that, if they're finding it quite easy, then you start distancing out where to place that resistance to have them work and work harder. Resistance may be applied across an intermediate joint if that joint is stable and pain-free, and if there is adequate muscle strength supporting the joint. So if we go back to the shoulder, if I feel that the elbow joint is not significantly structurally stable enough, maybe I put exercise bands across both arms above the shoulders to do abduction. Maybe I put strapped weights all across the biceps to do the abduction, taking the elbow out as an example. Revise the placement of resistance if pressure from the load is uncomfortable for the patient. So remember, you want it to be stressful. You want to have that overload principle, but it should not be uncomfortable or painful for the patient. The direction of the resistance. So during concentric exercise, resistance is applied in the direction directly opposite to the desired motion, whereas during eccentric exercise, resistance is applied in the same direction as the desired motion. So if we go to the arm and the biceps, if I want to concentrically work the biceps, it's bringing the hand up towards the shoulder. If I want to eccentrically work the muscle, I start with the weight with my hand up at the shoulder, and I control the lowering of my arm. The other thing is stabilization. So for non-weight bearing resisted exercise, external stabilization of a segment usually is applied at the proximal attachment of the muscle to be strengthened. So if you are applying the resistance, you want one of your hands to be proximal to the body at the joint to provide stability as the patient moves through. During multi-joint resisted exercises in weight-bearing postures, the patient must use muscle control to hold non-moving segments in proper alignment. So if you saw me in class, my classic example is doing arm curls with the patient, swinging like crazy to get the arms going. That's not what we want. If I want to strengthen those biceps for whatever reason, then I want the legs a good shoulder width apart to stabilize the core, tighten the core to keep the body from moving at all, and just the biceps perform the task. The intensity of exercise and the amount of resistance. Intensity must be consistent with the intended goals of resistance training and the type of muscle contraction. So what are the goals of the training? What kind of a contraction do we want? Initially, have the patient practice the movement pattern against minimal load. So maybe you're the minimal load. So you ask them to perform it for you and you provide the resistance so they get a feel of how it's supposed to feel when they do it. Have the patient exert a forceful but controlled and pain-free effort. So pain-free is the key here, and controlled. So they're not whipping the weights around and doing all the things you might see in the gym all the time. Adjust the alignment, stabilization, or the amount of resistance of the patient. If the patient is unable to complete the available ROM, muscular tremor develops or substitute motions occur. The thing to remember, at any time if you see the patient cheating, adding or providing extra movement or muscle contraction to the movement, it's likely they're too weak to perform the task and they're starting to cheat. You've likely given them too much to start with and you need to back off. You want to be able to see them perform the exercise without a lot of what I call cheating or extra movements in regards to the exercise that they're doing. So how many repetitions do we have them do? How many sets? How much rest? Generally, we start with a weight that the patient can do comfortably in 8 to 12 repetitions against the exercise load. So if you're not doing the 1RM, which a lot of you aren't trained for, and I get it, you want to do a weight. So you always err on the less side. If the patient can do 12 and not even say it's difficult, then you need to up the weight. The reality is, depending on what you're wanting to do, if it's strength or endurance, when they get to the last repetition, it should be difficult and they should be close to exhaustion. That's what you want to look at. So we are after muscular fatigue and adaptive gains. Remember, we need to stress the tissue out in order to have it adapt to get stronger. Decrease the amount of resistance if the patient cannot complete 8 to 12 reps. So that's the idea, is that if they can't even get to 4 or 5, you've got way too much weight. You need to take it back and get them up to that 8 to 12. Remember, first minute is where the body or where the muscle recoups the best. If they can only get to 4 and it's too hard and you find they're quite exhausted, wait that 3 to 4 minutes before you take the weight down to see if they can do the 8 to 12. After a rest, perform additional repetitions. So for progressive overloading, initially increase the number of repetitions or sets, later increase the weight. General rule, 3 sets of 15, up the weight. So if they start and you've given them a weight and they can only do 8, you ask them to work to 12, and maybe then you ask them to work to 15. If they can get to 15 with that weight, then you go back to 8 repetitions with a heavier weight and work the way up accordingly. Verbal or written instructions, keeping it simple theory applies. Don't make it difficult. Don't make the exercise prescription excessively convoluted, because they will not remember any of it the moment they walk out the door. Quite often you start with maybe 1 or 2 exercises, next appointment 3 or 4, and so forth. You keep it simple. Assess the patient's responses before, during, and after exercise. You really need to have them back to see how things are going with them. Because this week, if I give you an exercise prescription, I want to see you next week. You might walk in the door and say, you killed me, you inflamed me back up again, I can barely function. Or they may say, this was way too easy. You need that information, it's vitally important. Cool down. You have to have them cool down. General stretching works well for this. And cooling down with rhythmic, unresisted movements also helps as well. But cool down is vitally important. So, precautions. Valsalva maneuver. A Valsalva maneuver is defined as an expiratory effort against a closed glottis. In other words, you may know it as bearing down. So, you're trying to have a bowel movement and you're holding your breath and forcing to try to go to the bathroom. That is a Valsalva maneuver. It's very dangerous, especially when weightlifting. You must not have the patient do this. They have to learn to breathe through all the movements in their exercise. What happens with the Valsalva? It increases intra-abdominal and intrathoracic pressures, which in turn forces blood from the heart, causing an abrupt, temporary increase in arterial blood pressure. Not good, especially if your patients have previous heart attack or coronary artery disease, or they've had a stroke or suffered from mini strokes and hypertension. So the bottom line is you must constantly remind the patient not to hold their breath while exercising. They have them breathe. Generally, the rule is one exhales when lifting and inhaling with lowering. Okay, so exhaling during the working phase, and inhaling during the relaxation phase. I've alluded to this a little bit, substitute motions. If you've put too much weight in, they start adding substitute motions. You start looking around in the gym now that you understand this, and you watch how many people actually have substitute motions when they're doing the work. Because there seems to be this big thing about having big honking weights in their hands or big plates, makes them look cool and hot, but they're doing substitute motions. One or two things out of substitute motions. First is, it doesn't allow the isolation of the muscle you want to get stronger. And secondly, those substitute motions, you may be asking small muscle groups to do excessive amount of work and increase the possibility of injury. So no substitute motions. The thing is, the patient doesn't realize it. The body uses other muscles to perform the work without you consciously being aware of it. So the brain knows if I'm asking it to do something, to lift something or push something, unbeknownst to you, it's calculating what needs to be done, and it will bring in what it feels to be stronger, better muscles to do the work. So you always have to be aware of that. So what happens is you need to work on correct stabilization to prevent substitute motions. So always keep an eye out for substitute motions when you watch and observe your patient doing the exercises. Exercise-induced muscle soreness, also known as DOMS. But first thing we have to talk about is the acute muscle soreness. So obviously when you're doing hard, heavy work, you have some soreness and uncomfortableness in the muscles acutely. So what happens is, as the muscle's contracting and doing the work, it's actually squeezing off its own blood supply, causing what's called ischemia. You also get a buildup of metabolites such as lactic acid and potassium. Lactic acid is very acidic, so the muscle burns when you're working it, right? You get that feeling of burning or aching. As soon as your set's done, that very quickly disappears. That is an appropriate sort of uncomfortableness. This is where you know that you are stressing the system out to make adaptations of strength, right? It's when you get too far into that pain where it's starting to not just hurt but cause harm. That's when you need to back off. So as I said, delayed onset muscle shortening after any form of muscular overexertion, delayed onset of muscle soreness or shortening, which is noticeable in the muscle belly or muscle tendinous junction, begins to develop anywhere from 12 to 24 hours after the cessation of exercise. High intensity eccentric muscle contractions cause the most severe, and the worst can last 10 to 14 days. Just check on page 196 in your REMX book. You'll see some discussion around DOMS. Current research suggests that DOMS is linked to some form of contraction-induced mechanical disruption or microtrauma of muscle fibers and or connective tissue in and around muscle that results in degeneration of tissue. It is not caused by lactic acid. If you remember when you took your metabolism lecture on ATP, lactic acid is quickly converted because it's reused as a fuel source. Lactic acid does not cause delayed onset of muscle soreness. In other words, then, the evidence now says inflammation and edema because of the microtrauma. To avoid it, it's suggested that the patient progress gradually by performing low-intensity warm-up and cool-down activities, but again, there's no evidence that supports this. When don't we do resistance training? Pain during testing, prior, or during the exercise, reduce resistance. If even with the reduced resistance, If pain continues, stop. Inflammation, we do not do resistance exercise on any tissue that is inflamed. Acute inflammation in a joint also constitutes a contraindication to resistance exercises. Severe cardiopulmonary disease. So severe cardiopulmonary and respiratory diseases is a CI to resistance training. If your patient has had an MI or a heart attack or a CABG, which is a bypass, resistance training should be postponed for at least 5 weeks. And of course, you're waiting for clearance from the patient's physician. You do not make that decision yourself. The one part that doesn't get discussed enough is manual resistance training. So far, all of you have probably related it to machines, cables, dumbbells, all sorts of other things. But I wanted to have a brief conversation here around manual resistance training. A form of active resistive exercise in which the resistance force is applied by the therapist to either a dynamic or static muscular contraction. There is no reason why, while the patient's on the table, you cannot be the resistance to help work somebody through some strengthening. You don't know the exact resistance you're placing, so you want to get some feedback in terms of how difficult it is for the patient. And obviously, you're not trying to supply enough resistance that they're shaking on the table because they're working so hard. When joint motion is permissible, resistance usually is applied throughout the available range of motion as the muscle contracts and shortens or lengthens under tension. So that's what we're after. You are applying it. It's carried out in anatomical planes of motion. Or you can have combined patterns of movement that simulate functional activities. So it could be that you're just asking an arm curl through that single plane, or maybe you are providing the resistance while they perform a work task that has them in a particular type of posture or position in order to perform it. A specific muscle may also be strengthened by resisting the action of that muscle by itself. And that's one of the neat things that we can do. You've learned muscle testing, how to isolate a muscle. Do you see how strong it is? You can apply that exact same position with either you as the resistance or a dumbbell as a resistance in order to have them move through to isolate just one specific muscle for work. This may be preceded by active assisted and active exercise as part of the continuum of active exercises available to the therapist. So please remember one thing in particular, that you can be the resistance, that can happen, especially in the early days when a patient may be extremely weak because of a condition or surgery or something like that. We can provide the resistance. So what do we consider when we're performing manual resistance? First is your body mechanics. Obviously, if you're going to apply the resistance, you want to be in a position where you don't get harmed. So good posture, good positioning, good stabilization of yourself so you're not getting pulled off your feet or anything at all. Application. Well, you got to stabilize. As I said, if you're using an arm to do the work, one hand should be proximal to stabilize the joint, with the other hand being as far away as appropriate to provide the resistance. Remember, the farther the arm is, the moment arm is, to the resistance, the harder it is. So if you've got Arnold Schwarzenegger on the table and he or she is particularly strong, you applying that resistance farther along the limb makes it easier for you for the therapist and allows the patient to work harder. Verbal commands. Obviously, you want verbal commands while you're providing this resistance, so you're talking them through how to do it appropriately. Maybe when they start adding in other movements. You can immediately stop and address that. Number of repetitions and sets and rest intervals. Obviously, the response of the patient determines the number of repetitions. The strength and endurance of you as the therapist is how long it can go on for. And of course, build in adequate rest intervals so the patient and both the therapist can get what they need in terms of rest. Thanks for listening. We got one more slide in resistance training. We'll see you next time. Thanks. Bye.